Good afternoon, everyone. Thank you so much for joining the Alzheimer's Foundation of America and our Care Connection webinar. We are so excited to have Dr. Irit Felsen with us today for prior trauma, aging, and the experience of care recipients. Before we go ahead and get started, I would love to just orient those of you to our webinar if you are new. Please note every single participant of the webinar is in listen-only mode, so you are all muted. If you have questions throughout the webinar, please feel free to go ahead and type those questions in on that right-hand side panel underneath the tab that says questions. We'll go ahead and provide the answers to those questions at the end of the webinar. Also on that right-hand side panel, you'll see that we have a section called handouts. We've got today's presentation as well as a few other educational materials listed in that handout section. Feel free to download those handouts at any time. If you have any other questions, again, feel free to type them in and we'll go ahead and answer the questions at the end of the presentation. So without further ado, I'd love to introduce Dr. Irit Felsen. She is a clinical psychologist born in Israel and living in the United States, specializing in the treatment of trauma and traumatic loss. Dr. Felsen is an adjunct professor at the Yeshiva University in New York City, a researcher with the Yale Trauma Study Group, and maintains a private psychotherapy practice in Mountain Lakes and in Englewood, New Jersey. AFA is so excited to have you with us today, Dr. Felsen. Please feel free to go ahead and get us started.
So a good day, everybody. Thank you so much for joining us today. It's a great honor to be a part in any way of the work of the Alzheimer's Foundation of America. And without further ado, we'll just get right into it because we have so much to get through. So just one second. Modern gerontological theories take a lifespan perspective on aging, which means that the individual reactions to the many challenges of aging differ very much according to the personal life history of each individual. It was put very beautifully by Heikkinen in a WHO, World Health Organization conference in Geneva at the time, which I just would like to share with you. She said, the way in which we grow old and experience, just one second, let me collapse the dash thing on the side, and experience this process, our health and functional ability all depend not only on our genetic makeup, but also on what we have done during our lives, what sort of thing we have encountered in the course of our lifetime, on how and where we have lived our lives. So let's start by briefly defining what is trauma. According to SAMHSA, which is the Substance Abuse and Mental Health Administration, trauma results from an event, an actual event, a series of events, or a set of circumstances that is experienced by the individual subjectively as physically or emotionally harmful or threatening, and that has lasting adverse effects on the individual's functioning and physical, social, emotional, or spiritual well-being. So these are the three E's, if you like: the event itself, the experience of it by the individual, because some people can experience the same event very differently, and the lasting effects on it, which are also greatly different among different people exposed to the same trauma. The PTSD definition was changed in the DSM-5 relative to the previous version. We all know that the previous version had the three very important clusters of symptoms that defined post-traumatic stress disorder, or PTSD. One was the intrusive phenomena, which included flashbacks, daydreams, fragments of memories intruding upon one's awareness during the day, and nightmares and the likes of that during sleep, during the night. So intrusive phenomena, hyper arousal, which included all the startle responses, the difficulties sleeping, all of the sense of being on your toes all the time and watching for danger. And the third cluster that included avoidance and numbing, of emotional responsivity, which may sound like a bit of a paradox. On one hand, one is very, very anxious and overreactive, but emotionally numb and less reactive than one ought to be to all kinds of emotional events in life, especially positive events and connections. So the main change that I want to point out in the definition of PTSD in the new DSM version is the addition of the cluster D, which is symptoms of negative alterations in cognitions and mood, which are associated with the traumatic event. So lasting changes in mood and in the way people act and the way people feel about themselves in the world, which really came to address the fact that the previous definition of trauma was more focused on symptoms and was more appropriate for single event traumatic type experiences, whereas the new definition includes our recognition that some traumas are more complex. And complex traumas are typically interpersonal as opposed to natural disasters or accidents. And they include exposure to repeated traumatic experiences, either the same type of trauma over a period of time or multiple types of trauma. And they involve situations in which the person cannot escape from the traumatic experiences because he or she is constrained physically, socially, or psychologically. So as I said, just to highlight the inclusion in the DSM-5 of the enduring personality changes following exposure to massive trauma attempts to address those alterations that we see in people that go beyond the symptoms as they were defined by the DSM earlier version, and to address the features of post-traumatic stress disorder that occurs after massive and prolonged trauma, as opposed to PTSD that occurs after a single traumatic event, such as an accident or even an assault. And these prolonged and enduring personality changes are also very relevant to people whom we would consider presenting with a subclinical type of picture, meaning they don't have all the symptoms that would suffice for a formal definition of post-traumatic stress disorder, but they have a lot of those symptoms. And what we see that even in people with that type of subclinical presentation, there are often these very significant enduring personality changes that very much impact their subjective sense of self for many years after the trauma and their relationship with significant people in their lives. So we have different types of trauma. We have childhood trauma, and we will talk a little bit more about the ACEs, as they're called, adverse childhood experiences. We have rape and sexual assault, which is a very traumatic event. We have domestic and spousal violence, which also have very, very severe impact. And we have disasters and mass trauma that are due to natural causes or technological accidents. We also have political trauma and torture, and we have combat trauma that pertains to veterans and people who are in combat theaters. And we also have a relatively new field, which is actually a field that I am very, very much interested and focused on in my work, in my research and my clinical work, which is historical trauma, which is the intergenerational transmission of events in the history of the family down the generations, the impact on generations in families that were exposed to genocide, persecution, slavery, displacement, and exploitation. We know that malignant trauma, trauma that is human perpetrated, has additional distinctly damaging and different aspects, which have to do with the fact that there was a malevolent intent, a directed sadistic cruelty by one person or some people against other people. And that particular aspect of sadistic, malevolent intent by people against people shatters beliefs about the self and about the world. The levels of post-traumatic symptomatology that we see in victims of political violence are much, much higher than in other populations that were exposed to disasters or natural disasters or accidents, even though the studies of victims of political violence tend to occur several years after the regime has changed or the political conflict has subsided, whereas our studies of disaster victims tend to take place quite immediately after the disaster. So even though they take place later, the rates of symptomatology are much higher in victims of interpersonal violence. The response of people to trauma is very, very variable. It has become clear over the last few decades based on many, many studies, initially mostly on studies of Holocaust survivors and gradually studies on Vietnam veterans, rape victims, crime victims, and now really the field of trauma has come to recognize that shocking events do cause serious damage to physical and mental health. It may seem like a self-evident statement at this point, but it was not the case for quite a while. It was not recognized that such a truth is the case. And in fact, the definition of post-traumatic stress disorder made its way into our professional nosology, into our professional lexicon and the DSM only in 1980. There is great individual variability in the response to trauma. So when we look at studies of various trauma-exposed populations, various traumatic events that happened, we see that between 10 to 40% of those exposed to the trauma show post-traumatic disorder symptoms in the first year after exposure and to a disaster, and as high as 80 to 90% of those exposed in refugee populations from war zones and torture victims. About a third of those who show post-traumatic stress disorder during the first year after a traumatic event spontaneously recover. About a third show lasting post-traumatic effects for many years, and the remaining third lies anywhere in between and constitutes that population that I referred to before, which might be subclinical, and yet their lives show a lot of issues and problems, almost at the level sometimes of those with a full formal PTSD. Among World War II children, those who were children during World War II in various countries, very high lasting symptoms are observed into old age. The World Health Organization had published in 2014 a very large study that was conducted in, I believe, 20 countries. A very, very large sample of over 20,000 subjects were involved, and their conclusions were quite clear that if one endures more than 4 traumatic events in their lifetime, so events that would constitute a traumatic, would fulfill the criteria for a traumatic event according to the DSM and the ICD, those people's lives show a much greater level of impairment and dysfunctionality. This is a graph from a meta-analysis by Barrel and his colleagues in 2010. They looked at 70 different studies of Holocaust survivors quite late at 2010, comparing Holocaust survivors that were community dwelling and also studies that looked at Holocaust survivors from what is called clinical samples. so people who had been sampled because they were in therapy in some way or another. And what you can see is that both community dwelling survivors and those who were in therapy were similar to other people, to the norm of their peers in most aspects that were looked at, such as total adjustment, physical health, psychological well-being, all of those other aspects. The two spikes that are clearly there in the middle have to do with post-traumatic stress symptoms. So many years later, many of the studies show that in that way, survivors of a trauma that occurred many, many years before continue to show a big spike in that area. They're different in that area. So when we talk about, as I said, when we talk about trauma, a lot of what we have learned about trauma and aging still has to do with studies of Holocaust survivors. That's the population. It's a very, very large population that was exposed to extreme traumatic events for a very prolonged time. And studies of this population began to be conducted somewhere in the, I'd say, really 60s and even later than that, 70s. And so we have data that covers quite a long period of time by now. So a lot of what I will say will be about Holocaust survivors, but we by now have also studies about individuals who and groups that survived other extreme traumatic events from South Asia, for example, and as I said, Vietnam veterans and others. And the pattern of findings is very consistent with what we know about Holocaust survivors. So with regards to extreme trauma, such as the Holocaust, what I often hear from well-intentioned and sensitive students when I talk to them is the question, is one really still affected after 60 years? Because the big picture is just too overwhelming. And I sometimes try to make it more conceivable by asking that person, imagine if someone told you that when they were 6 or 7 or 14, one day in the night, criminals broke into their house and murdered their entire family. Would you think that that person would still be affected by it after 60 years? Because it makes it a little bit less overwhelming than thinking about the impact of the Holocaust on people 60 years later. The details that people, the details of the experience, the experiences that people have endured are so inconceivable to us that we really cannot comprehend the actual grainy details. I apologize ahead of time to those of you who might find some of the details that I will mention as we speak perturbing. But then again, that's exactly the problem with trauma-informed care. This is exactly what we want to do, is to somehow overcome our natural tendency to not want to know about the actual details of terribly traumatic and horrible acts that people had endured and that people took against other people. So what does it mean, for example, to be without water for days or without food for weeks? What does it really mean when you stop to think about it? How does it feel? What does it feel like to wear thin pajamas in the snowy winter outside all day? What does it mean to walk miles on foot without proper shoes to work and back in any weather, to suffer frostbite, to not be allowed to go to the bathroom, to be soiling yourself and working this way all day and all night and on days like that, to not wash for months, to watch torture, to witness daily gruesome killings, to watch one's parents, one's children die in agony or be killed. How can we actually expect to be able to relate to that? So what we have to understand is that we really cannot, our minds protect us from being truly able to go there even momentarily. But we have to make a certain effort to just try as best we can. And I will tell you what happens to survivors. I'll give you here a few small snippets. My father was rescued by a very righteous man who hid a few Jewish people in his attic, and was betrayed by his own brother. So his own brother told the Gestapo that there were Jews hiding in his brother's house, and his brother, the righteous brother, and his wife were hung in the center of the town, so everybody would see and learn the lesson. Dr. Rosa, who together with me presented to physicians about trauma, described the situation where she and a whole lot of other women were collected at a church, where the priest told them to give all of their valuables to the person who will go around collecting it. And then he paraded in front of the women a wheelbarrow in which there was a woman who was dead and beaten to a unrecognizable pulp. And he calmly informed them that this is what happened to her because she tried to hide something. And just so that they would know, they should know that this incredible cruelty took place while she was still alive. She wasn't beaten this way after she was dead, but while she was still alive. So this is a priest. Um, in Hadamar, in Germany, I worked for the Israeli government in Hamburg for 4 years, and I had the good fortune of befriending the director of Hadamar, which was before the war a clinic for individuals with developmental disabilities and other disabilities. And after the war, when I met him, it was a school, a residential school for delinquent youth. And he showed me materials. He actually wrote his dissertation about documents that he found in the basement of the clinic that documented the euthanasia program that took place there, where nurses and doctors killed the residents, the developmentally disabled and other disabled patients in Hadamar Clinic. There are many, many other examples that I bring to you to show you why survivors might have a deep mistrust of people because they saw siblings, priests, doctors, nurses, police, militia, civilians show incredible cruelty. And so the fact that someone is a nurse or a doctor, the fact that you are a social worker or anyone else so dedicated to the care of others from your perspective, does not necessarily convince them right away that you are not capable of incredible cruelty or indifference to their suffering. They have seen betrayals and cruelty by friends, by friends, former business partners. I recommend that if you want, you can see the beautiful documentary that Billy Joel created about his family and how their parents were betrayed by business partners, by neighbors, by employees. Uh, the the survivors saw highly motivated, enthusiastic collaboration by many, many people around them. My own mother described to me how she came to the house where she used to live after the war, and she knocked on the door of the neighbor, and when they saw her, she managed to see the embroidered tablecloth from her own parents' home on the table, on the dining room table. And the person picked up a log of wood from the fireplace and told her, if you ever come back here again, I will kill you. That was after the war. So these are experiences that stay with survivors. And some of the persistent post-traumatic states that stay with them include the following. First of all, a profound recognition and memory of the failure of empathy that people are capable of. The perpetrators, the collaborators, the bystanders. Survivors' reactions, therefore, in the present, to any kind of perceived indifference or impersonal or demeaning attitudes may be completely different and may appear very, very exaggerated to us. So, okay, so we didn't respond right away, or okay, our tone was a little bit less pleasant than we meant to, but why is the person reacting so badly? Well, because they are incredibly aware and incredibly afraid of the other person's capacity to have no empathy. They also, because of that, may need to test people or take a much longer time than others to develop trust in us, in the treaters. The fear of abusive authority and of every other as a potential perpetrator is a very deep sense of profound mistrust, as I mentioned before, because they have seen priests and doctors and nurses and all kinds of people that were supposed to be, to behave differently, become perpetrators. The fear of loss of autonomy, of the fear of being confined, the fear of being robbed of one's belongings, of one's home, of one's own space, is tremendously powerful in survivors and plays a huge role in the way that they experience transitions into other living situations when they need to leave their homes or unable to stay in their homes any longer, because they have already experienced an extreme loss of autonomy and the dangers that go with it, a confinement, a loss of independence, and were robbed of all of their belongings and their homes and their spaces. Another very important thing to remember as a persistent traumatic state, it's the embodied experience of the self which surrounds the trauma. So it's the feeling in the body. What did it feel like to feel incredible pain, to feel incredible hunger? What did it feel like to be walking around sensing your own incredible stench and dirt and that of everybody around you, because everybody was smeared with feces that they weren't allowed to go and clean up from? What is it to remember the feelings of shame and debasement and fear and anger that go along with being reduced to such a state? Why is it very relevant? Because imagine, for example, a patient who needs a bedpan, and after she's done what she needed to do, she's left there waiting for the nurse to come and clear it, and she's demanding that it be taken away, and she's very impatient, and she's upsetting the nurse or the nurse's aide, who doesn't understand why is this person so demanding. Well, for this person, many of these experiences that I just described to you come up when she's smelling herself lying on her bedpan, and it's different, very different from the experience of someone, for example, like Maury in Tuesdays with Maury, who describes a much different attitude with which he was able to accept his deteriorating shape and the help that he needed in all of these very personal hygiene matters, because he had never been reduced to states of such shame and terrible feelings. There is also a profound, lasting sense of abandonment and aloneness, and an irrational response to it, which is often triggered non-consciously and sometimes more consciously. For example, there is a psychiatrist, Gabor Mate, whom you can listen to on YouTube, who describes, he's very successful, He was a 1-year-old baby during the Holocaust, and his mother just handed him over to a stranger to save his life. He describes that at one point he was coming back from a conference where he had been very successful, and he felt like a king. He was upgraded on the plane. He flew first class. He felt wonderful, and he was coming back home, and his wife was supposed to meet him at the airport to pick him up, and she wasn't there. His wife is an artist, and sometimes she got a little too immersed in her work, and he called her and she forgot herself, and she was coming to get him, and she was going to be a half an hour late. And he describes his profound anger and sense of abandonment that took him 3 days to get over, because there is such a profound feeling inside of a sensitivity and a vulnerability to being abandoned and to being alone. And the response is, in fact, many times irrational, and people around the survivors, whether it's adult children or friends or therapists, uh, may find it extreme, may find it too needy, may find it narcissistic, may find it controlling, when in fact it is really the profound sense of abandonment and aloneness that is triggered by those reminders of these earlier traumatic situations. And related to that is also another thing, which is a persistent, intense feeling of longing, which again can appear very demanding, controlling, overly needy, ungrateful, when the survivor is so much longing for the visit of their adult children or their friends, and expresses that it's never enough and it's never long enough, and people may feel very uncomfortable about it, but really it's just another reverberation of these persistent traumatic states. Molly, how are we doing for time? Okay. So the difficulties presented by survivors may include suspiciousness, which is the result of having been abused, observing atrocities, observing desperate acts, even by other victims. Controlling behaviors, they learn to count only on themselves and trust no one, and they're very afraid of loss of autonomy, but it may appear to us, to the treaters, as controlling behaviors. They may even be belligerent and explosive, because affective dysregulation is a very common phenomenon in people with PTSD when they are triggered. They may show secrecy. They may try to hide things from us, because their main coping mechanisms were hiding, blending, and suppressing their real self in order to survive, in order for people not to notice them and not to discover them. They may have extreme denial, such as denying that they don't see well and need glasses, or denying that they need a cane or a walker, because any weakness was a death sentence during the Holocaust. And they may have great difficulties making and accepting changes. As I said before, people who have lost everything and suffered multiple uprootings and even many traumatic experiences after the end of World War II may find it very hard to give up the security and the safety of the homes they have built finally after that was over. And the flooding or flooding by resurfacing of traumatic material can lead to really psychotic level re-experiencing and reenacting trauma. For example, I received a call by this man, Alex, who told me about his mother, who became psychotic in the context of the fact that her apartment, she had to be evacuated from her apartment, and the apartment complex had to be fumigated, which for her, as someone who survived Auschwitz and the gassing and is very aware of the gassing of other people, it was extremely disorganizing. So what we must consider as people working with trauma survivors is the persistence and the compulsive repetition or reenactment of trauma. Extreme trauma does not just go away. It actually stays and stays. And for some people, it stays, we see, for 60 and 70 years after the end of the trauma, the original trauma. The reactions to institutional settings and authority, we have to remember that they might have difficult reactions to these things because they saw institutional settings and authority figures act in unlawful and abusive manners. We also have to remember that there's a deeper communicative functions to them telling about their suffering. And therefore, the point is they want to have the experience of someone really listening patiently and attentively, and with a real sort of empathic response in the eyes, in the face, in our body language. It's more important than what we say. There isn't a right thing to say. Just listen patiently and attentively and be fully and really present for them. When they complain about all kinds of things, even if the complaints are silly, like my teeth tickle, or something that is really seems silly, irrational, or repetitive, remember that the function of it is to elicit empathy, and that is what's important, and not the content of the complaint itself. They need to see that they can reach an other who cares and who listens, and it's not about necessarily whether the complaint itself can be dealt with or not, is silly or not. Somatic symptoms are our psychic pain that speaks through the body. It's a beautiful statement that I came across somewhere, and I cannot even tell you who put it this way, but it is a very true statement. So remember, we do know that even in the absence of identifiable underlying organic or physical causes, we know that there are many, many pain conditions and somatic complaints that survivors of trauma truly suffer from, and we don't know why. We don't have a good understanding of it yet. So what we have to try and do is help the survivor separate the here and now from the traumatic past. We have to reassure them. We have to reinforce safety. We have to reassure them of the difference. We are not then and there. This is very different. You are very safe here. And very much reinforce connections with us, connections with their natural resources. That's a very, very important element. And in some ways, when we can repair some damage to reinforce such connections, that is a very good idea. Tragedy often results in silence. So some people cannot speak about their traumatic events. And so we can ask what's called little questions that help construct the details and enable them to tell their experience from a position of a narrator, not to be completely sort of immersed in it. Like, what date was it when they came to your town? And in which kind of transportation were you transported? Things that allow us to maintain the position of a narrator and tell the story rather than sort of be completely triggered into it. Be empathic, as I said. The voice, the gaze, the body language communicate caring and attention more than anything else. And of course, we try to be helpful with all our patients, but with trauma survivors, we have to be extremely careful to be particularly reliable and to be real, because survivors are exquisitely sensitive to duplicity and to distance from other people. And we need to keep a strength focus. So look for diversion and for opportunities for the survivor to create some sort of a legacy and achieve somewhat of a better integration, so that they will be able to live better in their old age. For example, I give you here the example of a patient who told me that his mother could not stop crying for 3 days after at some point, I think shortly after his father passed away. And he brought her to me, and she said, I cannot tell my sons why I'm crying. I'm crying because at the very end of his life, my husband looked at me, and he wasn't, by the way, cognitively impaired. he looked at me and he called me Machashefa, which is a witch. And how could he, after everything I did for him and after all the difficulties that I lived through with him, because he was very PTSD for many, many years, the husband. And, it was very important to help this woman look at it as well, despite how um, disordered he was, despite his PTSD, you did manage to do all of these things, and you did manage to give him such a nice family and create for yourself such a nice family. Look at what an accomplishment that was, actually, because even you can see how damaged he was. And it helped her sort of shift her way of looking at it to a better integration and feel better about it. I want to mention to you quickly a concept that I have come to recognize in my work with trauma survivors, which I call the dual reality of trauma survivors. So trauma survivors continue after the trauma ends to live forever in a dual reality, where there is the reality of the here and now with the expectations, the interpersonal expectations, and the rules for behavior that are appropriate for life in society during peaceful times, and the reality of the trauma of inconceivable experience that are completely incongruent with the reality of the here and now. And I find it helpful to suggest a metaphor of like a glass floor, a transparent partition between the reality of the here and now that occurs above the glass floor with its norms and what is expectable from others and from the self, and the traumatic reality of what happened and what was expectable from others and even from the self under those traumatic circumstances. For the survivors of trauma, there is a continuous back and forth interplay between the two realities. They sort of see the two realities at all times, and each of the realities dominates the psychological perception and the emotional reaction to events in the survivor's life at different times and to different degrees. So internal triggers or external triggers can make the reality of the trauma rush to the foreground and completely overtake and dominate the response of the survivor to events in the here and now. At other times, the reality of the trauma can be sort of just in the periphery, and the survivor is able to really function and respond from the context of the here and now. The trauma lens, as Samsa put it beautifully, trauma can serve as a filter or a lens through which a person views the world. Think of sunglasses. You put them on and everything is shaded differently. Trauma can have that type of effect on how a person perceives their world. And I'll show you an example. This is a photograph of grapevines in the snowy mountains in Austria, taken by a friend of mine who's also a child of survivors, Dan Glaubach in Haifa. And when survivors look at this picture, what they see is this: survivors standing in the morning roll call on the in the concentration camp. This is a picture I took down from the internet, but it is a metaphor for something that a patient told me about, having walked in the snow in the winter and seen this pile of branches, which reminded him of what he saw in his past as piles of bones of victims of the genocide in Bosnia. This is laundry hanging in the to dry, which again I took down from the internet to demonstrate what another patient told me about, who saw people who were hanged. So when he see the laundry flying in the sort of moving in the air as it's drying, for him it is a very traumatic trigger that we cannot have imagined. So these triggers, the response to current stimuli, is very, very much determined at times by the reminders of past traumatic events, and the potential for distortion in the way that we respond to things that are happening right now. If we are survivors of trauma, the potential for distortion is much greater with ambiguous interpersonal, social, political events and relationships than even the distortion that occurs in our response to a concrete stimulus, such as grapevines in the snow or pants hanging to dry on a laundry string. The triggers might be completely invisible to others, of course, and so we will not know why the person is so distraught all of a sudden, or explosive, or whatever it is, or crying. And in fact, the trigger might be unregistered consciously by the survivors themselves, and yet evoke a very strong emotional or visceral reaction. So just so that we mention it, we have now over the last couple of decades, the new field of neuroimaging, which gave us a lot of information and showed that there are in fact specific changes in the brains of people who suffer from post-traumatic stress disorder. We see increased activity in the amygdala, which is the brain's alarm system. We see decreased activity in the medial prefrontal cortex, which is primarily responsible also for social decoding social interactions and social information. And we also see reduced hippocampal volume, which suggests that the constant high levels of hormones that have to do, stress hormones in the brain, might in fact lead to cell death in the brain. And these neurochemical changes, including increased dopamine levels, increased norepinephrine levels and or activity, and decreased serotonin levels and others, are also very much involved in the moods and the states of well-being that we see in survivors. These changes in the brain and in the neurochemistry of the body are especially significant for childhood trauma. So hello?
Excuse
Yes?
me, Irit. I'm sorry, it's Molly. I hate to interrupt you, but we've got about 15 minutes left, and we have a handful of questions looking specifically for some more details on how this relates to Alzheimer's. So I don't know if there's a
Yes.
way we can speed ahead, or if you want to go to question and answers. We've got 15 minutes.
So I will go just quickly to dementia.
Great. Thank you.
I will say that PTSD, post-traumatic stress disorder, and even subclinical post-traumatic stress disorder is associated, because of all of these impacts on the brain and on the body's stress reaction, with significantly worse health in general. And it was actually suggested that what it causes is premature aging of the body and of the brain. And in addition to the increased risk that it creates for multiple illnesses, it has been associated with much, much greater odds for dementia and cognitive impairment. So for example, the odds for veterans with PTSD were shown to be more than 2 times higher than for people veterans who were also in the same combat theater but did not develop PTSD. It is possible, it's suggested, and we don't know yet exactly, that the relationship is a bidirectional one. So people with PTSD are maybe more susceptible to dementia. And also, when dementia sets in, the prior defenses that people had to keep in check their post-traumatic symptoms are gone. And so the post-traumatic symptoms surface and come to be expressed. So it is very important that we understand why the likelihood that we as therapists and treaters and those who have relatives who have Alzheimer's, that all of a sudden people will have post-traumatic symptoms that they did not show for decades before. It's important that we understand that this is very possibly related to traumatic histories, and it is extremely important for therapists and treaters and healthcare providers to understand that, in fact, because of the damaging effects of PTSD and trauma on physical and brain health, the likelihood that we will find people with traumatic histories in any of the facilities in which we work with elderly people is much, much greater than in any other population, because those people have a much higher likelihood of developing physical problems that will require intense help or dementia. Did that answer the question?
Well, I'm going to go ahead and read specifically the questions if you're ready for the question and answer piece, or if you want to just touch on anything else before we get to question and answers.
So I would just like to mention one more thing, which is very important to me. Two things. One is that post-traumatic stress disorder or post-traumatic symptoms, or any, however you want to define, the level of it, are very, very much underdiagnosed in general and terribly underdiagnosed in the elderly. So very, very often, the person with Alzheimer's will certainly not be able to tell you about their trauma that occurred maybe when they were 5 or 6 or 14. The relatives may not feel that it's in any way relevant to the problems that this person is showing now, but based on what I just told you in all of those other slides and minutes that we spent together, there is a very high likelihood that the person is suffering and responding to those things nonetheless. So it's very important that we will be aware of it. And when we can, we need to ask the person. When we can, we need to ask the relatives about potential traumatic history. And when there's nothing else available, we need to try and understand where the person lived and when, and what were perhaps the events that happened in that context during that time that they might have been exposed to. The other thing that is incredibly important to me to mention is that I would like people to know that it's very, very helpful to post on the walls of people with Alzheimer's, whether it's in the hospital room, the long-term facility room, or at home. It's very important to post large, like quarter-page size pictures of the person at a time when they were not so old, when they were, so to speak, very much like the prototypical human, which is much closer to the kind of also age of the therapists or the treaters or the healthcare providers, who are usually not in their old age. Preferably, as I say, quarter-size photographs, because they trick our brain to thinking that this is a real person, as opposed to just a little object that we're looking at, such as when we're looking at a little photograph. Preferably when the person is engaged in some interaction with another person, because it makes it more alive. It reminds us that they had context, that they had relationship, that they were loved, that they loved other people. And preferably, well, that I'll just stay with that, and I'm happy to take questions now.
Excellent. Thank you so much. So we've got a handful of questions. And again, folks, if you're looking to write questions in on the right-hand side panel, there is a question section. Feel free to type it in and we'll go ahead and get it answered. So
Molly?
I have the, yes, Irit.
Can I just add one little sentence, which maybe will make a connection clearer? The reason why it's so important for me to say this thing about the photographs is because studies in neuroscience have shown us that our brain, even the brain of very well-intentioned people, and for reasons that I cannot get into necessarily right now, when we see the world, we immediately categorize things to human and objects. And when we see something that looks like a human, we then categorize it as human as me or less human than me. And those people who our brain perceives to have a mind that is not fully working are at risk to be perceived as less human than I. And when we perceive someone as less human than I, that is in fact the meaning of dehumanizing perceptions, and they are then at risk for us to lose empathy for their pain and for their general well-being. This is why people with Alzheimer's, of course, are at great risk to be perceived by our brains, even the brains of well-intentioned therapists and caretakers, as less human than I, and are at risk for lesser degree of empathy. That's why it's so important.
Excellent. Thank you so much for sharing that. And I know we do talk in all of our work in dementia care about how challenging dehumanizing our clients can be, our patients can be, and how it often can be so quick, especially during burnout. So I'm glad that you brought this up in this scenario as well. Let's go ahead and get to some of these questions. We have a question from Wesley that says, how about patients that repress their trauma and do not have recollection of the events that occurred? Any comments or advice on this?
Yeah, so first of all, I think it really behooves us to always just include questions about a possible traumatic history as part of what we collect about the information we collect about any person, any patient in all other arenas. So it shouldn't be something we don't touch or wait for the patient to raise. If they do not want to speak about it, we need to respect that, of course, but that does not mean that we should not be aware of the fact that their responses to all kinds of things in the present may still be very much informed by their past. So we need to be very sensitive to it, even if they don't want to talk about it.
Excellent. Yeah, I think that's great. And again, we always encourage, and it sounds as though the sentiment is true from what you're saying as well, is that if you're about to get into a conversation about trauma, is that you as the clinician to make sure that you know either how to handle that conversation or where to refer to. And of course, AFA's National Toll-Free Helpline is a wonderful resource if you're not sure where you can best assist your client or your person when something like this pops up. So very, very good. Now, we've got a great question from Brenda. Talk therapy is very difficult with dementia. So how do we provide measurable help to dementia residents who are living with PTSD?
So, first of all, I think one of the most important lessons is to just be very aware of the way that we construct their environment, the way that we move around them, the way that we talk to them. These are very, very important aspects that are not psychotherapy per se, but are incredibly important in caring for people with dementia and with trauma histories. Also, I would strongly recommend, of course, I'm sure many of you know, I would strongly recommend, and I have the link to it. I'll show you, I think, at the end of my slides. There is a link for a very good video that you can find on YouTube about snoozelen, which is a very calming way of providing sensory distraction and relaxation, and it can be done with relatively very simple and limited means, really, and I'll be happy to describe more if people want. I think that art therapy is a great way of letting people have some outlet when they're not verbal. Um, I remember seeing phenomenal work done and a great impact that it had on a person who was quite demented when he was given the opportunity to paint, what are they called, these round things, mankalas or something like that, you know, these round painting books that are available for adults, not for children, for adults.
Absolutely. There's a variety of different artistic and non-pharmacological interventions that can assist in the therapeutic and nonverbal communication that we can have as for care partners with individuals who are living with this illness. And so thank you so much for sharing that information. And again, AFA can also provide particular interventions that you may want to use, because we do feel mandalas is the, thank you, Robert, for that word,
yes,
mandalas.
Right.
But certainly AFA can help provide with other resources, because we do believe that you can engage in therapeutic interventions with a person who's living with dementia. It just might look a little bit different from your traditional talk therapy.
Very much so. And by the way, Molly, there is a very beautiful documentary called I Remember Better When I Paint.
Yes, yes, excellent. Thank you so much for sharing that. And we've got a bunch of questions about the PowerPoint. And as a reminder, the PowerPoint is available in the handout section on the right-hand side panel. And also, this particular presentation will be recorded and archived on AFA's website, www.alzfdn.org, under the Caregiver Resources tab. We've got a few more questions to go through for those of you who want to hang on a few more moments. There was another question. If a consumer with PTSD is caring for a consumer with dementia, could this explain why caregivers are developing dementia as well when they are caring for a consumer with dementia? And this question comes from Donna. So Donna, I'm sorry, if I could just intervene really quickly. A person is going to develop dementia for a variety of different reasons, and it's not always going to be because they're caring for someone with dementia. It's not something that you could potentially catch in that way, but go ahead in terms of PTSD, yes.
Right. No, I think that when a consumer with PTSD is caring for someone with dementia, then, you know, clearly it's going to be even more difficult for them for all the reasons that I mentioned, because really even their response to the fact that they are losing that other person, the abandonment, the aloneness, the fears of being alone, the fears of dealing with all of that, the fact that they cannot reach the other emotionally, all of those things go right back into the issues that I mentioned as very vulnerable points for people with PTSD. So their reaction, the caretaker with PTSD might have much, much more severe reactions to the terrible, tragic reality of having to care for a spouse or a relative with dementia than maybe someone else. And they're I don't think that they're at greater risk for developing PTSD, but they are certainly at greater risk for developing depression.
Excellent, thank you so much. And again, being a care partner for any person can be challenging and stressful, which is why it's so important that we're reaching out to networks for further support so we can all, both care partner and individual living with this illness, can live a meaningful life. Thank you so much. And so there's a question from Susan here. So it is encouraged that the senior talks about their history. So you're saying you are encouraging that?
I'm sorry, I couldn't understand that.
So the question comes from Susan saying that that you are saying it is encouraged that the senior talks about their history.
I don't think that I would say that as a blanket statement. I would say that it is encouraged to give the seniors the experience of someone sitting down and being really fully present and asking them small questions, such as, so where were you born? Or when did you come to this country? And then you give them a chance, if they want, to tell you more, and if they don't want, to tell you less, but they can gauge how much they want to say, and if they want to get into the traumatic material or if they don't, and they still have the experience, which is so important, of someone giving them that kind of full presence and interest and empathic listening, with at the same time being very sensitive to letting the senior decide if they want to answer the small question with small information or to go deeper into the traumatic information.
Excellent, thank you so much. And I think what you're talking about, right, is our person-centered care and making sure that we don't count out one of our clients simply because of their diagnosis. We want to always be able to provide the space for that human connection and the opportunity to share. And Susan does have clarification on her particular question. When I asked before about whether we should encourage seniors to talk about their trauma, I mean just during a typical day or time on their unit, when they're having a conversation versus during a therapy. And I think you captured that really nicely, Dr. Felsen, in that whenever a person wants to speak, whether it's formally in a therapy session or if it's coming up during an activity or a point of engagement, we should certainly always allow that opportunity for an individual to speak and share their story.
Yeah. Right.
Excellent, thank you so much. So there are a few other questions again about the PowerPoint. There's questions about evaluation of the webinar. Please know that you can always reach back out to us. I believe there is a short survey that will finish when we close the webinar. You can always reach out. If you can go to the very last slide, Irit, you can always reach back out to us via email or phone.
Just one second.
Sure. Our phone number, for those of you who have any further questions or concerns, please feel free to give us a call at 866-232-8484. You can also give us, send along an email. Again, my name is Molly. I'm the director of our education program here. Heather is on vacation today, so I'm facilitating it, and you can always reach out to me if you have any further questions. M as in Molly, Fogel, Fogel, at alzfdn.org. The slide deck that is in the handout section also has Dr. Felsen's information on it, including her blog. And so certainly we do appreciate your time today, Dr. Felsen. We really appreciate all of this information. Again, slide decks will be on the handouts, and this webinar will be listed on our website. Thank you again so much for a wonderful presentation, and thank you all for joining us today.
Thank you very much, Molly, for the opportunity to be part of this incredibly important work that you do. And thank you, everyone, for taking the time to listen to this presentation today.
Thank you. You all have a wonderful day. We'll be going ahead and closing the webinar at this time. Thank you so much.
Bye-bye.